So I'll be speaking on whether it is possible to prevent PC tear and the anterior rupture. See, I just like to remind here that these two are different entities. Posterior capsular tear and anterior rupture are independent entities. That's what I'd like to highlight to this short presentation. So this is a case where I'm in the last fragment. I already know that the PC tear has happened, and because of the shape is irregular, I thought the anterior is also ruptured. Now watch very closely what happens here. So now there is something like a small bomb which is blasting is. No, actually there was no anterior rupture then. When you AC shallowed, it causes the anterior to rupture. Again you can see, the second wave is the one which is causing an anterior rupture. So it gives us enough time to stop it at just anterior posterior capsular tear itself. And if we are alert enough, we can prevent the anterior rupture. So these are two independent entities one has to remember. So this is what is the basic message which I want to give it to you. Now this is a posterior polar cataract, and I have noticed a posterior capsular tear here. And at every stage we are all taught that we need to maintain the chamber, and the best way to do is to use any viscoelastic dispersive OVD is the best. And I am trying to visco-dissect using the dispersive OVD itself, and as careful as possible you are trying to remove all the lens matter. The principle is never allow the chamber to shallow. The only secret is you need to go as slow as you can. You can see that the posterior capsular tear it's staring at me, but still you'll be successful in preventing the anterior rupture if you can follow these basic steps. So I'm using sodium hyaluronate to create space within the bag now, and then I'm going to implant the lens into the bag itself with an open PC, and with a very low bottle height you can even remove the OED from behind the lens. The only secret is never allow the chamber to shallow, and you have visual outcomes which are almost indistinguishable from a routine one. This is another case where you have a post-occlusion search, and you can see that the posterior capsule is torn. The only thing which you have to do before doing anything else is never allow the chamber to shallow. That is the secret here. So what you do is, before removing out, you just have to, because this is a posterior capsule rexus, because of the round thing, it's unlikely to enlarge, but we don't want the anterior to rupture. The same principle, don't come out just like that in panic. If you come out, then you lose the opportunity of preventing the anterior rupture. So if you want to remove cortex, dry aspiration is a good way to do it, but technically sometimes it may be a problem because the cannula gets blocked. You can use fluid as well, IEA, but use it very low bottle height. The secret is bring down the bottle height to as low as you can, and you'll be surprised that if you can control the turbulence, even with the fluid going in, you can prevent the anterior rupture. And if you follow these basic principles, most often than not, you can prevent the anterior rupture happening in spite of having an open posterior capsule. So that should be the take-home message here. The only secret would be, maintain the chamber equilibrium well. So I think I'll just skip the couple of cases because we'll be running out of time. So I'd just like to conclude by summarizing this basic principles which I want everyone to understand here. So anterior need not be ruptured whenever there is a posterior capsular tear, okay? It can be intact. These are two independent entities. Anterior appears like an invisible membrane. We see it only when it ruptures. It appears like a round hole as you saw there. So remember here, both are independent entities, and in a substantial number of cases, if you are very alert, you can prevent the anterior rupture. So what do you do to achieve this? How can we, apart from diagnosing it early? So one probably most important thing is always, the secret is you have to maintain the chamber. The secret is in the chamber. So never allow the chamber to either suddenly deepen or suddenly shallow. Both are equivalent. The secret is equilibrium has to be maintained. So prevent sudden deepening and sudden shallowing. Now how do you prevent deepening? So avoid having a very high infusion pressure, lower than the bottle height, then adjust your parameters to ensure that the chamber doesn't shallow. The second weapon we have is the dispersive OVD. This acts like a barrier, and this prevents, it compartmentalizes, and it also prevents the gush of the fluid going across beyond it, and this will prevent the anterior bearing the brunt. And if you're careful with these situations, most often than not, you can prevent the anterior rupture. You can just note down the questions. At the end, we can take answers, question answers. And moving on to my second topic here. So, Dr. Vasavada has very beautifully demonstrated that, by going through the past planar way, we can prevent the enlargement of the posterior capsular tear. It is technically not so difficult, but when you're doing surgery under topical anesthesia, sometimes, what happens, it becomes a little bit cumbersome for us to, again, give a block, enhance, or do this, but you have to do it. But my idea is, can we achieve the same goal by going through the limbal approach itself? And if so, what are the principles we need to apply? So, how can we achieve the same advantages? Again, the first, principle is not going to change. You will always have to maintain the chamber. And using a dispersive OVD, which has a contractant sulfate and hyaloid combination. Second, which is often missed upon, is the bottle height. So you're operating, when you're doing phacoemulsification, the bottle height is set at 90 centimeters. And when you start doing vitrectomy, you again keep it at that only. That is one which is going to cause us a lot of problem. So watch out for the infusion pressure. Sudden raise in the infusion pressure in a deep chamber where it has become unicameral, that is going to blow out the posterior capsule. And third important principle is try to position your vitrector such a way that the principle here what we are following is you're trying to divide the vitreous which is prolapsed into two segments. First, position the cutter below the level of the posterior capsular tear with the port facing down and cut all the vitreous which is beneath it. So by this you're trying to transact the attachment between the one which is prolapsed and which is behind the level of the posterior capsular tear. So once you start with the port being posteriorly, and then you turn the posterior sideways, and lastly you turn it anteriorly, then only the cut and prolapse vitreous is then removed out. By following this principle, you are having a higher chance of preventing the enlargement of the PC tear in spite of going through the translimbal route. And of course, last, the rhexis. If you can do a posterior capsular rhexis, then you definitely have significant advantage. Now, you've got two circles here. One is the posterior capsular tear, one is the anterior hyaloid rupture. So, both of them have ruptured in this situation. So, as I fill OVD, you can see the vitreous trying to gravitate towards the side port. It is indicated by, the distortion of the capsular tear, clearly suggesting that the vitreous has found its way to the side port incision. Now, what do you do now here? First, obviously, you're going to stain it. And first I begin by just cutting the vitreous at the wound itself. And remember, at this stage we are not even enter the chamber. So preferably first, because the chamber is now maintained with the dispersive OVD. So what I do is first I go in with the cutter. Now not much of a cutting is happening, Once it goes and after few cuts, then only the chamber, the infusion enters in, and the bottle height, remember, it is as low as 20 or 25 centimeters. Look at the position of the cutter there. The cutter is positioned, the port is faced downwards, and first you do a little bit limited vitrectomy, and once the fluttering of the margin is an indication whether the vitreous is still present in the vicinity or not. So once, if there is no vitreous, the fluttering starts to appear, that is a sign that, you have taken care of the vitreous around the tear. All this is happening in very, very gentle environment. There is no turbulence at all. Okay, if you have higher infusion pressure, it's going to rip open it. So once you're done that, then you're going to turn the port sideways and then anteriorly. And at this stage, after doing vitrectomy, it continues to remain the same, tear. Then you're going to do a PC tear, the rhexis. The advantage of doing rhexis is that while implanting your lens, the tear does not enlarge. That's the reason why we have to do it. So, to summarize it, always maintain, never allow it to shallow. You have got higher chances of decreasing the rate of PC tear enlargement. Use low bottle height, that's important. And third would be, position your port appropriately. So this is one thing which is not highlighted, the infusion pressure. People forget to just lower it as you start doing vitrectomy. And if you just, it blows open. And the position of the port is something which I'd like to take a note of. Start by making it posteriorly. And of course, you are going to use the highest rate and the lowest flow rate and vacuum. Basically, you're trying to do it in the least turbulent environment. Just it's cutting. And lastly, the last part is the one which you're removing anteriorly. Now, this is a care where, you have posterior capsular tear, anterior rupture. In this case, I'm trying to do a PCC before the vitrectomy itself. You have a higher chance of success of, getting PC tear. The problem is, vitreous cannot be there. You have to push it down. Then only you can achieve a posterior capsular rhexis. Once you have a posterior capsular rhexis, the chances of the PC tear enlarging is much more lesser, okay, significantly lesser. And we have a nice Rexis like this. You always have got a chance to place the same lens in the bag itself without any issue at all.